And in terms of what we're going to be discussing today, we'll be talking about what occlusion myocardial infarctions are, why they matter, and how to identify them. So in terms of what an occlusion myocardial infarction refers to, it's really a physiologic paradigm that places the underlying pathology at the top of the schema. That is, if you're dealing with an acute culprit coronary artery, rather than a single segment of the ECG. In terms of why they matter because, as everybody in this room is well aware, when we're dealing with an acutely occluded coronary vessel, time is tissue, and that's true whether there's significant elevation of the ST segment or not. And then in terms of how we'll identify occlusion myocardial infarctions, you'll have to take my word that it does take a fair bit of practice, but I also know that this audience is well aware of that as well, since many of you guys are OMI experts here. But since this is the age of artificial intelligence, we'll review a model that seems to be promising in terms of helping us to identify these. So just to delve into the paradigm itself, historically, when we're approaching acute coronary syndromes, we've been taught to dichotomize them into two buckets. And if we see significant elevation of the ST segment, we tend to think that there's probably a completely occluded coronary vessel below, possibly with a predominantly RBC-rich thrombus. And if the patient has a good story for acute coronary syndrome, but we don't see significant elevation of the ST segment, we might presume that we're dealing with an incompletely occluded vessel, possibly with a more platelet-rich thrombus. And this is kind of important because it shapes our management. And when we're dealing with a significant ST segment elevation, we're really trying to do our best to expedite revascularization with an ideal first medical contact to balloon time of less than 90 minutes. But if we're dealing with a similar case, but we don't see significant elevation of the ST segment, we are reassured that we have a little bit more time, can be a little bit more conservative and manage the patient with just some initial heparin and antiplatelets while awaiting angiography. Now, if this were a perfect paradigm, we would expect perfect overlap between those who have total thrombotic occlusion and those who are presenting with ST segment elevation. But in reality, we know that that's not the case, and that about 30% of these turn out to be false positives. And that's for a variety of reasons, including early repolarization, pericarditis, Takotsubo, left ventricular hypertrophy, bundle branch blocks, aneurysms, embolisms, and brugada. And about 30% of the time, these turn out to be false negatives. But you can't really call them false negatives because if you find that the patient has a completely occluded culprit vessel at the time of angiography, but they didn't come in with a significant elevation of their ST segment, we just end up calling these NSTEMIs. So the proponents of the OMI and OMI paradigm propose starting with the underlying pathology, that is, are you dealing with an acutely occluded coronary vessel, and then look for some ECG findings that might support that underlying pathology. So one of them would be our current ST segment elevation criteria, but there might be other things as well. So everybody in this room is quite familiar with the Scarbosa or Smith-modified Scarbosa for identifying OMIs in the setting of a left bundle branch block or paced rhythm. There might be times where we just recognize a Wellens pattern. There might be times where there's non-contiguous ST segment elevation that doesn't rule in for formal STEMI criteria, such as that seen in the South African flag pattern or Aslander pattern. There might be times that you're just dealing with more subtle ST segment elevation that doesn't rule in for our current criteria, but there are findings that are highly suggestive of a acute thrombotic occlusion, such as the pattern seen in terminal QRS distortion or precordial swirl. There might be times that we're clued into an occlusion myocardial infarction by significant ST segment depression, such as when we're dealing with a posterior OMI, or even the de Winter T Waves. And finally, there are hyperacute T Waves themselves. So by the numbers, NSTEMIs account for about 70% of acute coronary syndromes, with STEMIs accounting for the remaining 30. But interestingly, at the time of angiography, we find that about 25% of these NSTEMIs are found to have total occlusion of their coronary vessel with TIMI-0 flow. And we'll refer to these as the STEMI-negative OMIs. And these guys with incompletely occluded vessels, NOMIs, or non-occluded myocardial infarctions. And it turns out if you multiply the total number of NSTEMIs by 25%, that shakes out to about 150,000 patients yearly in the US that have these STEMI-negative OMIs. So you might be wondering, should these STEMI-negative OMIs be treated the same as their non-occluded counterparts? And for some insight into that, we can turn to our latest 2025 ACC guideline for acute coronary syndrome. But unfortunately, they don't do much in terms of helping us to identify or risk stratify this particular subgroup. They do, however, remind us that if we're dealing with a high-risk NSTEMI, which I would argue these are, with GRACE scores greater than 140, there's a class 1 indication to do angiography in a routine fashion, so sometime before their discharge. But if you're particularly concerned, try to get them into the lab sometime within the first 24 hours with a 2A recommendation. Unless, of course, they're hemodynamically unstable, in which case there is a class 1 recommendation for trying to get them into the lab within the first 2 hours. So the reason that the guidelines have such confidence in this kind of conservative approach to NSTEMIs lies in 2 major trials, the first of which is the TIMAX trial that was published in the New England Journal in 2009. And in this trial, they looked at a cohort of NSTEMIs that were treated with either an early invasive approach, sometime less than 24 hours, or a delayed invasive approach, greater than 36 hours. And it turns out in the early arm, they tended to get revascularized within the first 14 hours or by hour 14, and in the later group, it was around hour 50. But in this trial, they failed to show any improvement in outcomes with respect to death, MI, or CVA. However, there was a trend towards an improvement if your GRACE score was greater than 140 in the early invasive arm. And then a similar trial was performed about 10 years later, the verdict trial. And in this trial, once again, they looked at a cohort of NSTEMIs. Once again, they looked to see differences between an early invasive approach and a delayed invasive approach, but this time they got the early arm into the lab a little bit earlier with a median time to cath of 4.7 hours compared to 62 in the delayed group. But once again, they didn't see any improvement in MACE with respect to death, MI, heart failure, rehospitalization. And once again, there was a trend towards improvement in the early invasive strategy if the GRACE score was greater than 140. But this is kind of interesting because now we're wondering, well, if you have the same lesion, an acute occlusion of a coronary vessel, but there's no ST segment elevation, basically, how would we act if there was significant ST segment elevation? Because in this situation, we know that time is tissue, and we see that there's increasing mortality with respect to the onset of occlusion to reperfusion in terms of in-hospital mortality, 30-day mortality, 1-year mortality, such that our 2025 ACC ACS guidelines remind us that with each 30-minute delay, there is an associated increased relative 1-year risk of mortality by 7.5% and a corresponding relative risk of transmural necrosis by 37%. And also importantly, we know that from the duration of symptom onset to revascularization, there's kind of a critical time-dependent window. And if we overlay the 2 trials that we just looked at before that we're looking at early versus delayed approaches, we can see that the early arms in both of these trials were slightly beyond that period of critical time-dependent revascularization. So some might argue that part of the reason we didn't see a difference in the 2 groups is that the window had already passed for significant myocardial salvage. So now you might be wondering, is there any evidence that STEMI-negative OMIs have worse outcomes than their non-occluded counterparts? That is, again, if you're dealing with this acute, completely occluded thrombotic lesion, but it doesn't have significant ST segment elevation, do we have data to suggest that we should really be comfortable treating all these guys the same? And for some insight into that, we can turn to a 2017 meta-analysis published by Dr. Bott and his colleagues. And they looked at over 40,000 NSTEMIs and found that at the time of angiography at about 24 hours, 25% had TIMI zero flow with a culprit vessel. And that in this group, there was an associated 1.7-fold increased risk of mortality and around 1.5-fold increased risk of MACE in the survivors. And if we dive into the component trials, we can see that in the largest trial that comprised 30,000 NSTEMIs, there was a 1.7-fold increased risk in in-hospital mortality. A similar number was seen in a slightly smaller study of 2,000 NSTEMIs. And one trial even showed a 2.5-fold increased risk of 30-day mortality. And studies that have looked at the time to cath for this subgroup found that the STEMI-negative OMIs tend to get to the lab about 10 times later, with an average of 440 minutes compared to 40 minutes if there was significant ST segment elevation. So that left the authors of this study, including Dr. Bott, concluding that better risk stratification tools are needed to identify this high-risk subgroup of ACS patients to facilitate earlier revascularization and potentially improve outcomes. And also left him thinking, how can we identify this important subgroup of NSTEMIs? So for the next part, we'll take a look to see, is there a way that we can identify this important subgroup so that we can help expedite them to the cath lab with the same certainty and urgency that we do for STEMIs. And for that, I'd like to reintroduce this paper recognizing electrocardiographically subtle occlusion myocardial infarctions and differentiating them from their mimics, 10 steps to or away from the cath lab. And this was published by an interventional cardiologist in Turkey, Dr. Aslanger, along with the kind of pioneers of the OMI paradigm, Dr. Steve Smith and Dr. Pendle Myers. And they break this approach to recognizing OMIs into 10 steps, with the first half predominantly focusing on distinguishing OMIs from their mimics, and the second half focusing more on identifying some of the more subtle ECG findings. Of course, if we were to consider any of these patterns, it would be nice if we could trust that there was some reasonable specificity for identifying OMIs and their mimics. And fortunately, in the literature, there is quite a bit validating these patterns with specificities ranging anywhere from the 80s to high 90s, to the point that our very own American College of Cardiology has started to cherry pick some of these patterns and place them under the bucket of STEMI equivalents in their 2022 ACC expert consensus pathway. So the first pattern here that they mention is distinguishing a left bundle branch block from a left bundle with an OMI. And I know this audience is quite familiar with this pattern, so I'm not going to dwell on it, only to point out that it was really only for the first time in 2022 that it got any form of somewhat formal recognition as a STEMI equivalent in this consensus pathway for acute chest pain and ED. I also know that you guys are experts at identifying and distinguishing LVH and LV aneurysms on the ECG from their mimics, as well as pericarditis and early repole and Wellens pattern. And while I recognize that the South African flag pattern has emerged as a fan favorite among many of our fellows, in the interest of time, I'm just going to focus on this last three subgroups of OMI patterns. The first of which I'd like to highlight is terminal QRS distortion. And I think that this is a nice example. This is a 29-year-old man who presented to the emergency department with chest pain. And at first glance, you might take a look at his EKG and appreciate that there is some ST segment elevation in leads V3, V4, V5, but also that it kind of has a upward scooping appearance, and he's a relatively young guy. So it might seem reasonable to chalk this off as early repolarization. But this pattern of terminal QRS distortion refers to the absence of both an S wave and a J wave in either leads V2 or V3. And if that finding is present, it turns out it's relatively specific and concerning for an occlusion myocardial infarction. So if we zoom into his leads, V2 and V3, we can see that sure enough, he lacks an S wave. There's no dip of this waveform below the baseline. And also importantly, there's no following J wave, an extra little jiggle. Now, for a comparison, here's a 65-year-old man who also presented to the ED with chest pain. And at first glance, his precordial ECG looks very similar. And if we zoom in, once again, we see that there's no S wave dipping below the baseline. But here, he reassuringly has a little bit of an extra jiggle afterwards that we can call a J wave. And this finding makes it less concerning that you're dealing with acute OMI. Now, unfortunately for this 29-year-old individual, about 30 minutes after this ECG was obtained, he went into a VFib arrest. And despite multiple attempts to resuscitate with ECMO, autopsy ultimately revealed a thrombotic occlusion of his LAD. And this finding of the terminal QRS distortion was nicely described in a 2016 paper that found that terminal QRS distortion was never observed in benign early repolarization, with 0 out of 171 patients with benign early repol having terminal QRS distortion, such that the specificity for LAD occlusion was 100%. But the next OMI pattern I thought we could discuss is that for to identify posterior occlusion myocardial infarctions. And just to re-highlight that this is also now considered a STEMI equivalent in the 2022 ACC consensus pathway. And to discuss this, I thought this was a nice case, one that came through our emergency department a short while ago. This is a 48-year-old man coming in with substernal chest pain. And at first glance of his ECG, it might not look that impressive. And certainly, if you're one of the cardiology fellows that's currently studying to code ECGs for the boards, if you're considering a posterior myocardial infarction, you might be looking for an R to S ratio greater than 1 and leads to V1 or V2. And if we zoom into his, we certainly don't see that here. And even if you just reference the ACC consensus pathway, they also recommend looking for a R to S ratio greater than 1 in lead V2, which again, we don't see. But if we scroll down to lead V3, we see that there is a slight bit of ST depression. And we also know that that's not usually normal. A part of the reason that the criteria for STEMI has an increased criteria in leads V2 or V3 is because we tend to see elevation normally at baseline. So a depression is a first flag of there being a possible problem. But it turns out that this finding of having maximal depression in leads V1 through V4 compared to leads V5 and V6 is relatively specific for OMIs. And if we zoom into the rest of his precordium here and take a look, we'll go back, we see that in leads V5 and V6, there really is no ST segment depression. And although subtle, it's maximal in lead V3. And sure enough, he went on and was found to have a completely thrombotic prox RCA that was promptly revascularized. And this finding of maximal ST depression in leads V1 through V4 compared to V5 and V6 was nicely described in a 2021 paper. Some in the audience might recognize one of the authors, Dr. Kane, who was a former fellow here, as well as some of our current emergency department colleagues, both Dr. Singers. And what they found is that this pattern had a specificity for OMI of 97%. And importantly, they found that in 34% of the occlusion myocardial infarctions, the ST depression was minimal with ST depression less than 1 millimeter. The one other OMI pattern that starts with an ST depression worth mentioning is the De Winter T wave. And there's not too much to say about this one. It really just comes down to pattern recognition. But I will just also highlight that as of 2022, it's also considered to be a STEMI equivalent. And here's a nice example that came through our emergency department. A 70-year-old man with substernal chest pain. This was promptly identified by one of our former fellows, who's now an EP fellow. But it starts off with a ST depression evolving into a broad symmetric hyperacute T wave. And this patient was found with a 100% thrombotic occlusion of his proximal LAD. that was promptly revascularized. And the last OMI pattern that I thought we could discuss today is that of hyperacute T waves. And once again, these are now considered to be STEMI equivalents. And to start this conversation, I thought I would start with this ECG, which is that from a 75-year-old woman who was coming in with intermittent heartburn. And if at first glance you're not particularly impressed with this EKG, you're in good company. Unfortunately, she was found with an acute thrombotic occlusion. But the best paper out there about hyperacute T waves at the moment was published in 2023. And they highlight that hyperacute T waves have no formal EKG definition, and that expert consensus just says that they're best defined by some increased area under the curve of the T wave relative to the QRS amplitude. And the authors go on to try to kind of objectify or make this more reproducible by figuring out a specific ratio. And they highlight here in this figure that, if you have an area under the curve of the T wave that's large relative to the preceding QRS complex, that's more concerning for an OMI than if the preceding QRS complex is larger. But you might be wondering, if this is a STEMI equivalent, should it be better defined? And the same authors of that prior paper currently have this paper under review, but they said it was okay for me to share some of their data. But what they're doing here is that they're now applying machine learning to actually integrate the area under this T wave, compare it to the preceding QRS complex. They perform a logistic regression on this, and then add to that what they refer to as a symmetry score, and apply logistic regressions to all of these, ultimately yielding a hyperacute T wave score. And they found that when the hyperacute T wave score was greater than 0.7 in 2 contiguous leads, it was highly suggestive of an OMI. So if we look at our patient here, our 75-year-old, who was coming in with a chest pain, and apply that machine learning model to her EKG, we see that sure enough, she gets hyperacute T wave scores of greater than 0.7 in several contiguous leads. And what's nice about this case is that she actually had a baseline EKG from a few weeks before presentation. And what we can see when we compare the two is that, initially her T waves had a nice kind of isoelectric segment, but at the time of this presentation, they had inflated, and the T wave kind of straightens and takes off right from the get-go. And just 2 minutes later, we see those T waves continuing to inflate, such that by 10 minutes later, they're even more inflated, with some significant J-point elevation. Now, when this model was applied to her baseline ECG, you can see that the scores were very low, nowhere near threshold, but when applied to her presenting ECG, it recognized these as hyperacute T waves with scores greater than 0.7 throughout the precordium. So once again, what this model is doing is it's looking at the area under the T wave, comparing it to the preceding QRS complex, and then calculates a symmetry score defined as the peak of the T wave to the end compared to the beginning to the peak. The closer these two are to each other, the closer the ratio will be to 1, the higher the hyperacute T wave score. So, oh yeah.
When you say the preceding, do you mean comparing V3 to V4 and V4 to
Oh no, just the QR, just like if you compare the QRS complex to just like this to the T wave, yeah. But again, as you guys know, and for anyone in the audience that doesn't, you'll have to take our word that identifying these patterns takes practice. But now that we're in the era of artificial intelligence, we'll take a look at a model that's being trained to identify these. So this model from Myocardial, which is called the Queen of Hearts, is being trained by the authors of this paper that we were walking through today, Dr. Smith and Dr. Myers. And they teamed up with one of their colleagues across the pond, Dr. Herman, to build and train this model. And what the model allows you to do is it allows you to take any picture of an EKG with your phone, or you can take a screenshot and upload it from your computer, and it will analyze it through AI network, and then try to decide if they think that it meets criteria for an occlusion myocardial infarction, recognizing that the rest of the world hasn't adopted that terminology. If it's concerned, it will now report it as a STEMI equivalent. And it also has a kind of visual overlay that they refer to as the explainability that allows you to kind of peek under the hood and see what leads they're most concerned with. This model underwent international evaluation with over 3,000 EKGs between Europe and the United States. They listed their one of their outcomes as a culprit vessel with TIMI 01 or TIMI 0 or TIMI 1 flow. And then they took those EKGs and tested them against different blinded responders. So the first was the OMI model itself. The second group was a group of cardiologists applying strict STEMI criteria. And the third was a group of OMI experts who turned out to be the authors, Dr. Smith and Dr. Myers. And what they found was that in terms of the sensitivity for occlusion myocardial infarctions, the model had a sensitivity for this outcome of 79% compared to applying strict STEMI criteria, which only had a sensitivity of 33. And then in terms of specificity, it looks like the STEMI criteria caught up and actually surpassed these other two groups. But what I'll point out is that the specificity of STEMI for occlusion myocardial infarctions was interrogated by Dr. James McCabe, an interventional cardiologist at the University of Washington back in 2013. And what he found was that there's a range between different subgroups of physicians, with interventional cardiologists having the highest specificity, but even the interventional cardiologists had a specificity of around 89%, which is still a bit lower, but kind of on par with this model. Now, while they were running that international study, in parallel, I was conducting a local study here at Stony Brook where we tested about 500 EKGs that came through the emergency department as either a heart alert or code H. We tested those through the model and then did a retrospective validation using a endpoint of a culprit vessel with TIMI 0 or 1 flow. And ultimately, it turned out we ended up with very similar results. So at the time that I was using the model, it would stratify its confidence as either high, medium, or low. And when stratified for high confidence, it had a sensitivity of about 81%, which is pretty close to what they reported. It had a specificity of 93%, which was spot on with what they reported. And then if we considered it when it had a confidence of medium to high, that not surprisingly increased its sensitivity to 91 without taking too much of a knock on its specificity. So in conclusion, what we discussed today is that the occlusion myocardial infarction paradigm is a physiologic paradigm that starts with the underlying pathology, that is, are you dealing with an acutely occluded coronary vessel, rather than using a single segment of the ECG. We reviewed that in terms of why this matters is because when you're dealing with an acutely occluded coronary vessel, time is tissue, and that's the case whether there's significant elevation of the ST segment or not. And in terms of how to identify these, again, you guys know, and if not, you'll take my word that it does take a bit of practice, but we now have some AI models that are helping us to recognize these. So if any of this has piqued your interest in occlusion myocardial infarctions, there's really no better resource out there to learn about them than Dr. Smith's ECG blog. If you're not into blogs and more into social media, certainly recommend following any of his associate editors. And if you don't have time to go through all 1,300 posts on the blog, there's now a kind of SparkNotes version of the blog, affectionately termed the Occlusion Myocardial Infarction Pocket Guide. And you can access that either from the banner of his site or going to omiguide.org, or if you're in the audience and prefer a QR code, you can access that there. And just to give you a sense as to how the site works, it basically breaks these patterns down just as they did in that paper, but we'll give you examples that you can go through with a quick synopsis of the case. At the top, it will remind you what the criteria for the pattern are. And here, You can scroll through and see a bunch of examples of subtle posterior OMIs to kind of train your eyes. And then at the bottom of each of these, it will remind you of the sensitivity and specificity with links to the literature. There's also some links to additional resources. And if you're a nerd and want to know the whole paradigm timeline,